Hello and welcome to CGA Oasis. My name is Shiraz Gitaye. We continue our mentorship series with Dr. Paul Belzicki, dental surgeon from Toronto. He is here today to present a series of cases that amount to what he calls, I love amalgam and why you should too. So Dr. Belzicki, thank you very much for giving us your time, your expertise, and welcome to this Oasis conversation.
Good morning, Shiraz.
So can you tell our audience briefly what the presentation is going to be about?
Well, the presentation is just thoughts on the continued use of amalgam as a restorative material in diverse clinical situations where its handling characteristics surpass that of composite resin. And this was motivated by a lecture that I gave to the Students' First National Conference here in Toronto a few weeks back. Another motivating factor was another colleague contacting me, asking me to help with treatment planning a case where there was a lot of decay that was subgingival and difficult to access. And I think the third issue, and most importantly to me, is I needed a restoration, an old amalgam replaced that had been in my mouth for some 20 years. And I contacted a few of my buddies and they say, hey, I don't do amalgam anymore. I threw out my amalgamator. And I thought, well, how can you do that? You just handicapped yourself in a lot of clinical situations where amalgam would have saved you. And knowing my past experience, which is long, judging by my gray hair, you can figure that out. There are just problems with composite resin that I found. It's not being able to get a predictable contact each and every time, the problems with post-operative sensitivity, because I don't want to have a simple restoration put in and then have an endo after if I don't need one. And it's ongoing wear, and just amalgam is such a great, predictably robust material. That's what I wanted, and I had to find another old guy to put in an amalgam. So it's trying to reset the clock a little bit and just make people aware amalgam is still a viable restorative material. And that's the sum total of what they're going to come away with from this presentation.
Perfect. Before we go and see the presentation, a primer for our viewers. The video from the conference, of your lecture from the conference, the first student conference, will be available on Oasis pretty soon, so stay tuned.
Okay, now, I can't wait to see me.
So shall we go and see the cases?
Yes, let's go. So as advertised, the title of this post is Why I Love Amalgam and You Should Too. So before I dive into that, I would just want to go over this case very quickly. And it's a case where it's post-ortho, and we need to address the peg laterals. The bands have been removed, and the orthodontist wanted something done to address the stability so that nothing moved, because he's fought hard to get these teeth in place. So there are periodontal concerns before we address the restorative. And I'm a dentist, a GP, that does the perio and endo as well. So I took out my perio probe and found I could sink it in 5 millimeters. So I raised a flap. And here you can see that there's bone coming right up to the CEJ. So there's not enough cementum exposed for the gingiva to form its gingival attachment, a sound biological zone, which is so the skin looks all bunched up. So after doing that, I saw, boy, you know, it's not bleeding very much. So I was able to get a band on, or a rubber dam rather, and I thought, well, hey, I've got moisture control. Let me see if I can get my matrix in place with wedges, and I could, still no bleeding. So I went ahead and did the composite resin veneers for these teeth. I added a bit here and spent a lot of time, 15 or 20 minutes on these areas in order to generate good embrasure form, because this is going to drive how the tissue heals. And then I thought, if I did it on the right side, maybe I could do it on the left side. And that worked out well as well, as you can see. Got moisture control. Did the remainder of the osseous recontouring to develop a zone of attached gingiva, stitched it up. A week later, took the sutures out. And then a month or so later, the patient came back and the tissue looks great. So we have a very acceptable holding pattern using composite resin. Now, I put this in here in case any of the young kids out there think, well, he's just another old dentist who never learned any new tricks on how to handle composite resin. Trust me, I know how to handle composite resin. I put this in place because I just don't want to be perceived as an old Andy Rooney fuddy-duddy. I'll tell you that I possess the knowledge and the skills to match the appropriate dental materials with the diverse clinical situations I have encountered over 38 years. So I just wanted to get that out of the way. So we all have a philosophy of care, and we use that as a guide. And mine is, as licensed healthcare providers, we have a fiduciary duty to put the patient's needs above all else. And this is basically the golden rule. Do unto others as you would have do unto you. So as I see it, our task is to use evidence-based knowledge that you learn at school, plus clinical experience, combining that with exacting technique and durable materials to yield long-lasting restorations, because that's what I would want if I'm the recipient of care. And I have found that amalgam, cast gold or silver palladium, either alone or as porcelain fused to metal restorations, have proven very, very robust and durable over the course of a long career. And I've got about 10 years of experience with zirconia, and I must say that's a decent material too. Has its drawbacks, but as single units in the anterior, I think it's marvelous. So when we use materials, we have to weigh the risks and benefits, what the material will give us. And I always say to myself, what would I want in my mouth? Because I had to have a restoration done. Well, I reserve composite resin for anterior teeth, obviously for the aesthetic reasons that I just showed in the opening case. But I don't like resins for the posterior teeth, for bicuspids and molars. Okay, it's a small occlusal, I can get away with it, fine. But even then, there can be problems. First of all, I can't guarantee a tight contact with adjacent teeth. It's difficult to generate proper interproximal contour, particularly if it's an extensive restoration. Wear resistance and strength are poor compared to other materials. And there are problems with post-operative sensitivity. And resin is very technique sensitive. And some of their criteria are often beyond our control, no matter how skillfully we perform. So when I say long-lasting restorations, what is an appropriate definition for long-lasting? How long is long enough for a restoration to be considered successful? Your definition will guide your choices of materials and methods. And my definition is for life. Once I work on a tooth, once I restore a tooth, I don't want to come back to it again. Now, I know that's a bit of a pipe dream, and I know that's difficult in some instances, but that is the maxim. Because how many times can you cut into a tooth without getting a catastrophic event, either an endo or the tooth breaking away? So in my mouth, when I have to have that restoration replaced, I want an amalgam. Now, if 5.7 years is your definition of long lasting, then composite resin will do. And here's a restoration in tooth 47. This is a 23 or 24-year-old female. She had this restoration placed not too long ago, and from the day it was put in, it was problematic. It was bothering her. And 2-3 years later, this is how she presented to my office. Now, the problem with composite resin, as I said, is it's technique sensitive. You have to etch, rinse, then dry. Not too much, not too little. You have to apply your primer and your bond, or whatever generation you're using, it might be mixed together. Then you have to dry again, and then you fill either incrementally or in bulk, if you're delusional. And then you have to light cure adequately to make sure that you've gotten the light where it should be. Now, how are you going to do this in this situation with this restoration, where you've got a box extending down near the gingiva, where you have a shallow vestibule and the ascending ramus just lateral to this tooth? How are you going to keep that dry? Because you have to do this all of these steps within a highly regulated time frame for each one in a moisture-free environment. So I removed the restoration, and I was going to do a crown for this tooth. We had discussed this with the patient. I said, I may have to do endo, I may not, I'll see what happens. So you take this out and you can see there's decay under there. So an amalgam restoration was placed as a core, and then I put on a full gold crown. Now, she's 23, 24 years old. She's got that Kim Kardashian look down pat. But I spoke with her, and she said, what should I put here? I said, well, we were going to put porcelain fused to metal because I assumed you wanted a tooth-colored restoration. But I said if it was my mouth, I'd put in a full gold crown because I've got 2 or 3 of these in my mouth. They're over 30 years old, and I can eat and bite and chew anything I want without worry. She said, let me think about it. And I gave her all the reasons why cast gold is the best material to use. She went home, discussed it with her parents, came back and said, fine, do what you think is best. So when presented with the proper information, patients that are reasonable will make a good choice. Now, is there any unbiased scientific evidence for what I have observed over a lifetime, these problems with decay under these restorations? Now, I showed this slide on another post, but I'll just revive it here. Whoops. Now, from authority, and this are university researchers, they studied the breakdown of composite resin containing ester bonds by human and bacterial esterases. Now, just to review, our polymers, the resins that we use, are basically units, monomers, links in a chain, and they're joined by an ester bond. And most commonly formulated dental resins are methyl methacrylate-based polymers that contain an ester bond. Ester bonds are cleaved by water in a process termed hydrolysis. So here you have your H2O molecule, and when it gets close enough, this happens. It breaks that bond, forms new ones, and these things go their separate way. And now you've reduced your polymer. Now you can't get away from this. Otherwise, any argument you make against this basically goes against chemistry. So when you're shown all those beautiful little resin tags that you have indented when you make your total etch, that the resin tags finds its way down into the dentinal tubules, well, there's moisture there, and that moisture is breaking this down. And when I gave that presentation, I didn't want to mention any names because I didn't want to sound as if I was name dropping, and I didn't want to generate tons of emails for the researcher, but it was Dr. Yoav Feiner, and he's the head of prosthodontics at University of Toronto Faculty of Dentistry. And he authored this paper in conjunction with another gentleman, and it was in the journal, so I can divulge the name, and I got that information from him. So in that article, and I think you should read it, there's the release of these breakdown products, which I can't possibly pronounce, but these products have been shown to increase the growth and virulence of karyogenic bacteria that cause decay. And these undermining the restoration and leading to recurrent caries, hypersensitivity, and pulpal inflammation. On average, replacement time is 5.7 years. So that number, I didn't pull that out of the hat. That came from this paper. And I assume Yoav did due diligence when he was researching this. And it's mainly because of secondary caries and fracture of the restoration. So it's nice to know that there's sound clinical research that's refereed that vindicates what I have seen over the course of a lifetime and the choices I have made. So you can say, well, you know, amalgam, gold, like it's going against the grain of what people will accept. Well, these two crowns have been in this person's head for about 15 years, and he's a Bruxer, and you can see there's some wear here, but that's the way it's looked since I placed those gold crowns, because gold is a very forgiving material. It will sacrifice itself before it wears the enamel. And I'm not delusional. I know that where aesthetics are important in the bicuspids, we did place PFM crowns. but it's been functioning problem-free for 15 years. But lately, market pressures are increasingly guiding treatment choices rather than what's best for the patient. And it's Cosmopolitan Magazine and Dr. Google now define what is aesthetically and functionally acceptable. So 2 gold crowns you can't do, but sticking all of these metal studs in your face, this is a fashion statement. You can't have 2 crowns, but these 2 little metal puppies in your mouth are apparently okay. And as dentists, we're succumbing to that pressure. So those photographs, obviously, I gleaned from the internet, but these are photographs of my patients. So they come in with these wire loops. I mean, this is more visible than an amalgam restoration. And when you take a look at these things, there's a little bit of inflammation. Something's going on with the tissue. And this is the boyfriend, and he's got one of these things in his lip. And there's the stud or the keeper on the lingual side. And that's banging against the gingiva, starting to cause some recession. So I show them this, and what do they say? Oh, cool. So this is your new school. This is your new school patient. You can't put a silver filling in my tooth, God forbid, but stick a few staples in my eyebrow. This is a fashion statement. And getting back to other issues with composite resin, it's the wear. So I saw this patient in 2014. These restorations were placed, not by me. And 2 years later, he returned. That crown had fallen off. But take a look in comparison over 2 years, how these have worn and worn badly. Now, this gentleman is from India. I don't know what grains or foods they eat, but it just seems they have a diet that produces a lot of attrition and wear. So I put a new crown on that tooth, and then I placed these amalgam restorations here. And I know that these will last decades. How can I make that statement? Well, because I've put an amalgam since 1980, and I've watched all these restorations over the course of my career, and they do nothing. They just sit there and take the abuse decade after decade. So in dentistry, I always hear, or you see in magazines, game changers, paradigm shifting, and this changes everything. Well, if anything ever changed anything, it was amalgam. And since 1900, when its formula was standardized by the American Dental Association, it has proven to be a dependably successful material because it is technique insensitive. Achieving solid contacts is predictable, wear characteristics are durable, and the interface is self-sealing with corrosion products. So at a time in the early 1900s, no high volume suction, maybe this was done at a barber shop, who knows, where amalgams used to be placed, or in the battlefields in World War I and World War II. I mean, amalgam has proven itself to be a robust, durable, predictably successful material. And even when it does break, it breaks predictably, not with recurrent decay, but usually fracture of a cusp that you can see right there. So 99% of the time, this would get a crown in my office. But the patient said, hey, I've got a mouthful of all these fillings. Can't you fill it? And I said, yeah, not a problem. But if it doesn't work, we'll put a crown on after. So remove the restoration. And here you can see it's a little bit stained, but that's not decay. That's solid. I cut out the little proximal box that was here. It had a separate class 5 and the other cusp came away. Not a problem. Put in 4 or 5 retentive pins. Don't gasp. I know how to do this. I know how to do it well that I don't injure the pulp. Put a band on the tooth. And now I can take as much force as I want and drive that band up against that tooth. And I know before I ever started this case, I'm going to get a tight contact, which is something I can't predict with composite resin, because you push on it, the mush just goes off to the side and the band does whatever it wants to do, irrespective of what band. And I've got sectional bands and all of the other little bracketry that they say you should use. But I know before I start, I'm going to be a winner. And right after it's carved, and a few years later, it comes back, and I can see there's a little wear facet, and it's going nowhere. This will be here for decades. And even if a little bit more breaks off, oh, sorry. So in many situations, amalgam is the material of choice. You need to inform patients on the risk benefits of both materials. With composite resin, I'll tell patients, you'll pay more for less. I worry about contacts. I worry about post-op sensitivity. There's a lot of things that I don't like about it. And the ultimate proof that composite resin is more problematic for the pulp, well, just go take out your neighborly endodontist, get a few drinks in him, and he'll tell you they love composite resin because that generates a lot of work for them. I'd love somebody to do a study where the question is asked, you had a restoration just put in and it's painful. How many times is that composite resin and how many times is that amalgam? So as I said, those pin retained amalgams are durable. And here is that same patient, but a different tooth, tooth 46. I put this in 20 years ago, and he broke the mesiolingual cusp. Well, it was easy to take a burr and just prepare that tooth. And that restoration is rock solid. You can take temporaries on and off, and it does not dislodge. I've had the instance where it was a composite core, and I pulled off the temporary, and the core was stuck in the temporary crown. This doesn't happen with pin-retained amalgam cores. And I need to be successful 100% of the time. That's what I strive for. If it's going to happen once, it's too much. And even in this case, why a composite resin in tooth 18? Is aesthetics that much of a problem? So you can see there's a lot of decay in this area. There's technical limitations to this crown. There's an open contact. And you saw the wear pattern on this tooth, very shallow composite resin filling. Well, I had taken out 18, that had healed, and then I start to disassemble 17. So of course, a lot of decay under the restoration. And this is typically what I see. I'm not coming up with this. I didn't Photoshop this. This is what I see under these. So you take that out. And again, if you etched, like where's that whole total etch where it's supposed to lock into dentin and just stay there forever? Well, there's breakdown. That hydrolysis process continues. So there I picked up the MB2 just to show you I do due diligence, and restored this with an amalgam core buildup and put a DO into tooth 16. So this is how it got restored. And this should last decades. And I can make that statement because I've seen other ones last that long. And again, problems with generating proper contact and proper contour with composite resin is difficult. And even in this case, same patients, you can see somebody placed a composite resin, most of this tooth, couldn't get a contact, so cut in an amalgam to save the day. You take that apart, and what do you see? Well, where the amalgam was is okay. Where the composite resin was sitting, all recurrent decay. So endodontics had to be carried out. As opposed to this patient I saw in 2007 for other issues, but in this area, I could see that most of the tooth structure had broken away from this restoration, this amalgam restoration, which was secured with 2 posts. She didn't want anything done at that time, but I just thought it was neat that this freestanding post-retained amalgam was just holding up quite nicely while bits and pieces of her teeth kept breaking away. She returned in 2010 because more of the 47 had broken. So at that time, I did a pin-retained core, an amalgam, and there you can see it. There was probably a little bit of softening here, or there was a void, so I just squashed in some amalgam laterally. You can see it there, that's new amalgam up against the old one. And I made 2 splinted crowns and a single crown on the bicuspid. And that's been in function ever since. So an old amalgam has withstood more than the test of time. I mean, that's giving service like nobody's business. So another reason I like amalgam, because I don't have to worry about moisture. And often I find myself in situations where if there is recurrent decay and I start restoring these, and the treatment plan was to place crowns here. So I will take out all of the restorative material and get down to solid ground. What is healthy dentin and what is not, and get rid of that which isn't. So here I could see that I was close to the crest of bone. And I knew that periodontal surgery would be required to facilitate crown lengthening, so I could place a decent bevel and a decent margin in these critical areas. So once I've trimmed away all of the restorative material, and you don't want to cut amalgam, you don't want to trim amalgam with a high-speed instrument in the presence of a flap. I'll say that twice. Don't cut amalgam in the presence of a flap, because you'll drive the powder under the flap, you'll never get rid of it, and you'll end up with an unsightly amalgam tattoo. So you get rid of all the restorative materials ahead of time, and there's my margin. And it's in close proximity to the bone. So at that time, it's easy to do your osseous recontouring, and then you come in with your favorite bevel burr and generate a new margin. And if you feel you've gone too deep, you can take molar bone away. So as the restorative dentist and providing the perio is kind of neat, because I can play back and forth to get the optimum margin that I want in relation to where the bone is. And then in the presence of a flap, in the presence of blood, put my pins in, put a band on, and now you can put the band on atraumatically because the skin's out of the way. Plug your amalgam. It doesn't care about moisture if it seeps up under the band. And then carve this by hand. You can't walk away from the patient. If it sets and you have to use a rotary instrument, don't. So by hand, you can carve this. You put a blade instrument back and forth, and you'll generate the core. A neat little trick is once you've put a pin in, you have them bite down, and if you find that the pin is too high, it's easy to grab with these little needle nose pliers, which I've used many times. Take a round diamond burr and just lop that off. And then you've got your clearance. And you just go ahead, as I've done here, and I've placed my amalgam cores. And then at some point, the blood always stops, and you can see exactly what you have, and that it will be predictably successful. And just another plug for old materials. This is powder liquid methyl methacrylate, tooth-colored denture resin, if you will. And it's neat because you can use that in a moist environment to generate excellent fitting provisionals. So I've hollow ground that and then just reseed it with some new material so I could pick up that margin with good fidelity. Trimmed it, cut off the occlusion, the occlusal table, once I knew that these crowns would seat accurately, and then just have the patient bite down on mushy acrylic, go back and forth, and they generate a functionally generated path. And this is great when you have multiple teeth, because doing this, the tap, 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 and knocking off blue marks can be maddening. So here you just remove the excess, and there's your occlusal table. So old materials sometimes provide excellent service. 3 months later, tissue comes back. I don't have to worry about these things dislodging. I don't have to worry about post-op sensitivity, putting acid on a large part of the dentin. Re-prepare the tooth structure, because in all likelihood the tissue recedes a little bit after healing. So just retrim that. Take my impression, which is easy to do with healthy tissue, and then just reseat using the same 3 provisionals, just reseat it with new acrylic, trim that back, and then the day of insertion. That's about, under high magnification. This is just beautiful. This is a beautiful environment in which to seat crowns. There's not a molecule of blood anywhere. So proper management with old materials will yield high-tech, long-lasting results. And that's the radiograph. And I can assure you that will be there for decades, because I've done that same technique over the course of 3 decades, particularly on this patient, where we started in '84 and the last crown was put in 2002. And that technique, using porcelain fused to metal on a gold-based alloy with amalgam core buildups. Here, the endos were not done as a result of restorative endeavors. It was because over the years, we would just treat each tooth as it came up symptomatically. She would require endo and then crowns. So you don't have to combine perio and restorative in a complicated crown and bridge case, even for basic fillings. Sometimes using amalgam, having amalgam in the operatory can save you, can help you. So here's a case where there was decay. This was done, these are radiographs from a previous dentist, and the work was by a previous dentist. Only one composite restoration was placed here. And the patient left, had discomfort post-operatively, came to my office, and I said, oh, well, here I still shoot regular film, and I was able to tell that person, here, you've got a perio problem, and you've got root decay, and it's getting quite high up on the root. So you're going to need some periodontal therapy at some point, but I'll try to address the sensitivities. So composite resin, that was the composite resin that was placed. There was food being impacted in that area. So I wasn't sure what to do first. Should I do the perio first? Should I do the restorative first? And I thought, well, I don't want to do the perio first if I still have an area of food impaction and sensitive teeth, because I know I may make that tooth more sensitive with periodontal surgery. So I first thought, let me replace the restorations with solid restorations. So here I've taken out the composite resin, and deep in here is the gingival seat. How can one get a proper matrix to place a composite resin filling that deep into the tissue? I know I can't do it. And if I can't do it, I don't think anybody else can either. Sorry to say that. But I've got decay also here on the bicuspid, on the distal root. So once I got all these restorations out, I saw I was subgingival on most of these teeth. And I knew even managing this with amalgam is going to be difficult. So I picked up a scalpel blade and raised a flap. And you can do this if you're going to use amalgam. You can't do this if you're going to use composite resin. And here you can see these beautiful chunks of calculus that were interproximally. So perio was done, the periodontal phase was done first to bride the root surfaces, osseous recontouring to get rid of bony defects, and then start placing amalgam restorations. And you can get a band on that tooth because the flap's out of the way. You can take your biggest wedge, stick it in there, and you can matrix that effectively. Place that restoration, carve it, and go on to the next one. And now it's easy peasy, getting good solid contacts and a good seal at the gingival seat. And reflecting the flap, you can see, you can get in here with hand instruments without a rotary to abuse the root surface, but while the amalgam is setting, you can get in here with hand instruments and take as much time as you need, generating good contour interproximally. And here's that case. This was done in December. So it's about 3 weeks on. And yeah, those little craters, they'll fill in as the tissue rebounds and reorganizes. And you can see here, getting these margins, getting these contours are important because this is going to drive how the tissue heals. And the patient does not have a huge amount of postoperative sensitivity, virtually none at all. I was lucky. So you don't have to start big, you can start small. And here is an composite resin restoration that was placed under the tissue. I'm sorry I didn't take a photograph of this before I started, but I could just see the top of that composite. I don't know how this was done without a flap, but I raised a flap and there was a failing composite resin there. So cut it out and then put amalgam in. Carve it, and then take a cotton pellet and go back and forth, back and forth. And you see the mercury phase that's on the sponge. So you wait a few more minutes and you do that a few more times till all of a sudden the sponge is clean. And then you know that you can close it and it will heal. And it will heal nicely without any amalgam tattoo. You do have, in this phase, by the way, you do have to make sure that you evacuate all of these particles. And it's easy to carve this by hand, and those big chunks will be sucked and washed away quite easily. Just don't use a rotary instrument. Going farther down the route, there was a resorptive lesion right there. Patient said when he pushed on that part, he jumped. So raised the flap, and there's that little resorptive lesion. And I was able to take a scalpel blade and just scallop the bone away, quite atraumatically, while leaving bone in the furcation. Put a little amalgam plug in there and closed it. Going through the same process to make sure that there was no residue coming off on the cotton sponge. And I know that I have sound cementum 360 around that restoration, and it should heal. And the endo was done as well because the tooth was symptomatic. And there's the tissue about 6 or 7 months later. A crown was placed, and there's the tissue some 4 or 5 years later. It's still there, still healthy. Going farther up the route, and I know some of the endodontists are going to make comments after this, but I also do root ends, and every year or every other year somebody needs a root end. I don't do it often, but in this case there was a large lesion here that required a nucleation right after the endo was done, and a small little amalgam plug was placed there, going through the same process of making sure I haven't left anything behind, burnishing that quite nicely, making sure that there's no residue, stitched it up, closed it, and it will heal. And here is one that I did in 1999. This film was taken 2014. So yeah, I don't need to look at a research paper to tell me amalgam is biocompatible and that the body will accept it. It just does. And I know newer MTA, I know that the newer materials are out there, but just historically, this is what we used to use, and it did hold up. So in my office, the delivery of long-term restorations is rule 1. And as I said, our task, evidence-based knowledge, plus clinical experience, exacting technique, and durable materials to yield long-lasting restorations, because that's what I would want in my mouth. And as I said, amalgam, gold, silver, palladium, etc. And yes, I love amalgam, and you should too. Because when you put a mirror in somebody's mouth and they take a breath, and now you have a layer of condensation on that mirror, well, there's that layer of condensation on your increments of composite resin as you're putting them in. And that's a weak link, and that's sometimes difficult to control, even with a rubber dam. So with that, I thank you. And I thank Oasis and the CDA for allowing me time on their presentation.
So thank you very much, Dr. Belzicki, for that valuable information and for sharing the cases. I want to make one comment. So basically, it's not that composite resin is not good, it's just that it's not as good as amalgam, and it's not always good everywhere in the mouth. Do I understand correctly?
When I hear somebody say I threw out my amalgamator. You've just handicapped yourself in so many clinical situations where moisture control is an issue. And you always can't get a dry field, particularly interproximally, up between molars, where the restoration is deep and your finish line is on dentin and cementum. Historically, ideally, composite resin bonding happens on enamel. If you have enamel, then the bond is predictable. But when you don't have enamel, the bond is not predictable. And as I said, in my mouth, to put in a restoration, a simple restoration where a filling is required on a molar, and then to walk out, bite down on something and pack food in, or have postoperative sensitivity, I don't want it for me, and I don't want it for a patient. I don't want to buy a problem. I don't want to make a problem for a patient. And the number of times, I mean, composite resin is a great practice builder for me because other people come from other offices and they say, I just had this filling done, you know, a composite resin. And it's the same old story. I just went back. Yes, I went back. They adjusted it. They adjusted it. So all the fine, beautiful work that they've done, aesthetically pleasing, that was done with all the contours, et cetera, et cetera. You can see all the burr marks where they said the bite must be high, the bite must be high, and they knock half of the tooth off. That's supposed to be conservative dentistry. You know, I have a material, and I often say this to people, I want to know I'm going to be successful before I start. Before I get into this tooth, I want to know that I can walk away and give you what I promise. And there's certain materials that can do that for me. Amalgam's one of them. I remember one of the first composite resin fillings I did was on a know-nothing molar, like a small little occlusal. It was nothing. I put in this little composite resin. Patient came back. I bite down on it, it's sore. I bite down on it, it's sore. On something that small, it just got me thinking. And then trying to get contacts. And because I do perio in the office, when you do your own perio, you become very cognizant of tissue, of soft tissue. And you know what it takes to get it healthy, and you know what it gets to maintain, what you need to maintain it properly. And to provide somebody with an open contact and food impaction problems, and then they come back year after year, it's bleeding is bleeding. I'm not that guy. So when patients say to me, well, all I want is composite resin, if I think I can manage it and pull it off, where I know I'm not going to give them a problem, I'll bend, but they still get the amalgam story. But if it's something I can't live with, you're free to go somewhere else. Come back when it's a problem, because I'll make more money.
Thank you so much, Dr. Bilzicki. I really appreciate it for giving us your time and sharing your expertise. Thank you.
You're welcome.